Hello and welcome to the Retina Radar podcast. I'm Arshad Khanani, Managing Partner and Director of Clinical Research and Director of Fellowship at Sierra Eye Associates and Clinical Professor of Surgery at the University of Nevada, Reno School of Medicine in Reno, Nevada. In each episode, I'll be sharing information on the latest breakthroughs, clinical insights, and practical pearls for your everyday use. We'll hear from leading experts, explore cutting-edge research, and discuss the trends shaping our field. Whether you're in clinic, in surgery, or on the move, Retina Radar keeps you informed, inspired, and ahead of the curve. To earn CME credit, visit mededtalks.com, search Retina Radar, or click the link in the notes to complete the activity and post-test. Before we begin, please review the faculty disclosures and learning objectives. If you have a question for our experts, send it to us at cme@vindicocme.com, and it may be featured in a future episode. This podcast is supported by an educational grant from 4D Molecular Therapeutics, AbbVie, Adverum Biotechnologies, Alkeus Pharmaceuticals, Astellas, EyePoint Pharmaceuticals, Genentech, a member of the Roche Group, Neurotech Pharmaceuticals, Ocular Therapeutix, Oculis, Regeneron Pharmaceuticals, and REGENXBIO. Today I'm joined by my friend and colleague, Dr. Aleksandra Rachitskaya, vitreoretinal physician and associate professor of ophthalmology at Cole Eye Institute in Cleveland, Ohio. Welcome, Aleksandra.
Thank you so much. It's such a pleasure to be here today.
You've been in the field for a while, and I've seen you do so many innovative things. You're involved with a lot of surgical as well as medical innovation. You're a leader in many of the novel techniques, and it's been really nice to see your career, flourishing over time. I think you started a little bit after I did, but you clearly have achieved so much. And I'm so excited because you're a true leader in surgical innovation, and we'll be discussing today, surgical instrumentations and techniques that are new so our audience can learn from you. So I'm really excited to have you on this podcast. But obviously, just like every other episode, before we dive into the topic at hand, we want to learn a little bit more about you. So tell us how you ended up doing what you do with your retinal surgery.
Well, thank you first for your kind words and quite a nice introduction. I appreciate that. It's really funny because I think we're so lucky in Retina, and I tell my trainees that all the time. I found Retina accidentally, and I couldn't be happier because if you think about what we do, we we see chronic patients, all our AMD patients or diabetic patients who are with us for life. We also are surgeons, and we take care of arguably some of the more complex pathologies. And we also are radiologists. We take care of all our imaging. And I just think it's so fantastic to have these great relationships with patients. And once I discovered Retina by being inspired by many, many mentors, you can't go back. So that's what drew me to Retina and what keeps me in Retina every day.
No, that's very exciting to hear. I agree. I didn't even think like that we are doing so many different things together, that they're actually specialties. So how long have you been in practice now?
I'm in my 12th year, believe it or not.
Great. You're doing awesome. So tell me the top 3 mentors you had.
Oh, that's hard to pick. There's so many. And so I trained at Bascom Palmer, and I was a resident there, fellow there, chief there. And there's so many mentors. I probably couldn't pick just the 3. And I think the other thing in Retina that's so fantastic is that there's so many different mentors, right? There's mentors you call when you have a complex medical patient, mentors for your surgical patients, for your research, if you're involved in national societies for life. It just attracts such a great group of people. And I think Retina is small enough where we have so many friends in the field, which is just fantastic.
No, I agree. I've had mentors I never trained with, but you give them a call, ask for advice, and then that's why I love our field, right? That everybody's so friendly, and as if we all train together, we didn't. But even if we don't work together, we're actually so close to each other. So, no, it's great. Bascom obviously is an amazing place, and there's so many big names there, right? From Harry Flynn to Nina to Albini. I mean, you name it. So I know you don't want to put anybody on the spot, so that was a good answer. So tell me about your hobbies. What are you doing outside your daily routine of practicing at Cleveland Clinic and teaching?
Well, right now I'm pretty busy because I have a 6-year-old at home. So my interest developed with him, and I progress as he progresses, from Paw Patrol to Ninjago. But I'm at the level of 6-year-old, so I can't tell you what's cool beyond that. And the other thing I like to do a lot, we travel a lot. And one of the things I do when I travel, if I get a chance, I try to jog in a new place. And it's just such a wonderful way to get to know a new place. And, walking sometimes, especially if we're traveling for work, it's kind of, you don't have enough time. But when you run, you can cover so much ground. So I love doing that when I can.
No, that's great. We love traveling too, and especially, as my kids have grown up more than, my oldest one is now almost 16, and you kind of see that transition, and then the traveling really helps them understand, how lucky we are where we are, and to learn different cultures. So no, that's great. Okay, so let's get to business at hand. We talk about surgery, but without imaging, there's no surgery. So share with us, how the recent imaging innovations, in wide field imaging, in OCT, OCTA, how has that helped you become a better surgeon? And of course, a little bit about intra-op OCT that you and Justice and team have pioneered at the Cleveland Clinic.
Yeah, I think you're exactly right. If you think about our surgeries, right? The saying is that the surgery begins in the office, and there's so much information that we're able to gain from imaging. It's really revolutionized the way I think about surgery. Your wide field imaging, right? It really helps you identify pathology and plan your surgical approach. And it's not only fundus photography, looking at our diabetic patients and doing fluorescein angiography wide field or doing OCT angiography in the office is extremely, extremely helpful for planning. We actually have been doing a lot of imaging studies. Particular interest to me is looking at retinoschisis detachments. Those are very complex, and doing that peripheral OCT is so helpful for us to identify pathology and see how we're going to fix those complex detachments. Also, very interesting is looking at adults who are born premature. We're seeing more and more of those patients in our clinics, and they're more likely to detach. And once again, doing some of the imaging, and our group and others have published on it, looking at OCTA. They have much smaller, much more vascularized foveolar vascular zone, looking at the peripheral retina with non-perfusion and very posterior insertion of vitreous base. All of that happens in clinic. And I always, I have trainees that I teach for surgery, and I always say, you have to think of so many variables and plan, and that comes really with the help of imaging. And then, as you mentioned, the imaging doesn't stop. We take our imaging now to the operating room, and we utilize heavily intraop OCT at the Cleveland Clinic. As you mentioned, Justice has pioneered that at the clinic and has published a lot of on evidence-based, kind of established evidence-based medicine and approach to intraop OCT. I use it in particular cases, and it's probably my preoperative planning that informs who is the patient who is going to be a good intraocular OCT patient. But for instance, just the other day, I did a complex detachment with schisis detachment and identifying that outer retinal break, inner retinal break. Sometimes it's super hard, and intraocular OCT was essential for me to really take good care of this patient. Or for some, pathologies in the macula, your VMTs, right? Sometimes you lift it up and you wonder if there's that tiny hole that happened. Well, you can image and show that there's nothing that occurred. And also now we're doing more and more of treatments such as gene therapy. And I think for those cases, intraocular OCT for initiation and propagation of the bleb is extremely helpful. There's also work being done on intraoperative fluorescein angiography. This is a much more niche kind of approach, but there's been publications on that looking for patients, let's say, who come with vitreous hemorrhage. You don't have any view in the back, and you can do intraoperative and kind of guide your treatment. Maybe it's from diabetes, or maybe it's from branch retinal vein occlusion. So that's super helpful. And then I think our imaging, when we think about surgery, then goes into postoperative period, because we're learning more and more about, it's no longer this retina attached or detached. Now we're looking at more imaging biomarkers to see how it explains patient experiences when it comes to distortions, metamorphopsia, or aniseikonia, and learning. And Rajiv Mooney has done a lot of work in that space. So I think that when you think about imaging, it's not only preoperative imaging, and it turns into intraoperative imaging and postoperative imaging, and it very much depends on the pathology. But I think as we image, we're not only able to plan better, but we're able to understand some of the pathologies better and be more successful and have higher success rates, both in anatomic and functional terms.
No, that's a very good overview. I totally agree with you. I think, I trained when there was very little imaging, and, OCT was just coming out, and now having the wide field imaging, OCTA, wide field angiography really helps us. And I think, the more you are plan in advance, the better the outcomes are, as you said. I mean, if you just go in cold with a schisis detachment, that's not for the sissies. I still regret those, but so next time I'm sending him your way, they can stay in Cleveland for a while, and I'm sure you'll fix them better than I do. But I agree. I think, the pathologies can be complicated, and I think looking at imaging, but also correlating imaging to the exam, right? What I see in young doctors that they're just focused on just the imaging. I think the scleral depressed exam in clinic, knowing the pathology. So I totally agree with you. I think it's an art in terms of how we use imaging and how it helps our surgical technique. And you mentioned that, we are doing a lot more unique or new procedures for common retinal diseases. The two that I want to discuss with you that you actually are very deeply involved with are PDS and gene therapy. So tell me a little bit about PDS. Our journey in PDS started, like a decade ago with Ladder and Archway, and then Pagoda, Pavilion, and Portal, and all these studies. And I remember, initially when Ladder started, it was shut down because of vitreous hemorrhages. And obviously, the laser was integrated in other things. But over the years, we have had a lot of innovation. And I think as an innovator, you probably can share with our audience about what did we learn from that program and where are we at now in terms of complications, because I think people need to understand the history that surgical innovations take time and you can actually refine them. So what are your thoughts?
Well, I think you're exactly right. It's surgical innovation is kind of a different way of, it's a different type of clinical trial when surgery is involved, because you not only have a therapeutic that you're potentially studying, but also your mode of delivery. And I was involved, I think you were as well, with Port Delivery System from Ladder. You might have been involved earlier because you start, I think, some of these projects. But it's really had has evolved. And I think what I would give a big thank you to all the investigators and the sponsor is how there was learnings that were taken from the earlier cases and then incorporated, because you can't, you might have a plan, but then you have to be able to adapt. So just like you mentioned, there was several things that I think have really emerged as time went on. And now we do have in US approval for neovascular AMD, DME, and diabetic retinopathy for port delivery system. But there was kind of three key things that I think have evolved as we learned how to do this surgery safer and more efficiently. The one that you mentioned is vitreous hemorrhage. So there were some cases of vitreous hemorrhage early on, and so there was this kind of development of a technique where you actually laser pars plana, and that's not something we've done in other cases, but it was essential for the success of PDS because the way the surgery is done. And so you actually, once you do the incision through the sclera, you administer laser to make sure that you establish so you prevent any bleeding. The other kind of key things that we learned, I remember going to one of the investigator meetings and having a glaucoma doctor teach retina doctors how to do surgery. And it has to do with the management of conjunctiva and tenons. And the reason being is that if you think about retina doctor opening conjunctiva and tenons, that's usually for scleral buckle, and you just want to get in there and get to the part that you're interested in. But port delivery system, you have to be extremely cautious and take care of conjunctiva and tenons because you don't want any retraction or erosion down the road that potentially could lead to a higher risk of infection. And there's different techniques that are being taught how to open the conjunctiva and tenons, how you want to, when you want to close, then again, tenons and conjunctiva. So it's covering the implant, and you have to be extremely careful in your manipulation. And I will tell you that those learnings from PDS, I take it to my secondary lens cases because once again, in those cases, sometimes you have quite elderly patients with very thin conjunctiva, and you don't want, if you use, for instance, the scleral fixated with a suture, you don't want any buttonholes over that suture. And so I actually felt that it benefited me beyond just the port delivery system. The other modifications that were made is to make sure that the size of the incision was exactly 3.5 millimeters, and that's to make sure that the implant was sitting properly. But I think if you think about it, there's so many patients now that have had port delivery system, and there's so many learnings that have happened along the way. There was septum dislodgement that wasn't related to surgery necessarily, but was related to the use of the implant in clinical practice. And I think it's just so fantastic that over time we've been able to address these things. And it's like anything new surgically. We had a brand new surgical device, and it's nice to see how seriously any of these concerns were taken. So as I mentioned, it's commercially available, and I'm also hoping that we'll see more studies looking at other therapeutics, other molecules that we can utilize the port delivery system.
No, that's a very comprehensive summary, and I agree with you. I think if you look at the adverse events from Ladder and Archway, and you look at the adverse events from Pagoda and Pavilion, definitely there is much improvement, right, in rates of endophthalmitis, in rates of, erosion or retraction. And I look at my own surgeries from Ladder, and I look at my recent surgeries from Pagoda Pavilion, very different, right? Because the conj and tenons were respected more. We, undermined. We made sure that there was an overhang. And so I think this is a great example of how surgical innovation is not easy, but it's doable with the shared feedback, as you said, all the surgeons and sponsors working hard to trying to get us there. So that's excellent. So next, let's go to gene therapy. I know you have been involved with many of the gene therapy programs, but tell us some of the latest innovation in the gene therapy space, because we have large phase 3 surgical trial with ABBV-RGX-314, Atmosphere and Ascend, and those are fully enrolled, and they're going to read out end of next year. So I think this is a skill that many of the physicians who are not in the trial will need to learn. So tell us a little bit about that procedure and the innovations.
So I think it's kind of interesting because as we started, right, when we were talking about what does it mean to be a retina specialist these days, and it's this combination of medical and surgical, and now we're seeing some of the diseases that historically have been managed medically becoming potentially more surgical diseases. So my personal experience is I've been doing gene therapy for inherited retinal diseases, and our site at Clone Clinic, we have also physicians who do the studies for neovascular AMD, for instance. And I think it's if you've never done gene therapy, it can be a little intimidating because you're administering something subretinally. Depending on the study, depending on the disease state, it's either peripheral or it can be actually submacular, which is even more nerve-wracking because you really want to be careful. And I think it's kind of neat to see as there's more developments in the gene therapy, we see more also developments in instrumentation and how we do it. Because, I don't know if we, hopefully we never see it again, right? When we had to have an assistant like pressing and it was still not controlled how the injections were happening. And now we can control it with the foot pedal, and we have intraoperative OCT to guide us. For instance, for a submacular gene therapy, you really want to plan exactly where you're going to go because in inherited retinal diseases, there's these patches of pigmentation, there's healthier retina, less healthy retina. So you want to have, once again, you want to have that plan from your imaging, from your clinical exam that you did in the office, and then you plan out and the administration, there is also technique to that, the steadiness to make sure that you get in subretinal space and propagate the bleb. I find intraop OCT extremely helpful for initiation and propagation, especially in the macula. You want to make sure that you don't create a macular hole, for instance, but in periphery as well. But it is definitely a skill that I think we're going to utilize more and more. As you mentioned, we have phase 3 clinical trials for neovascular AMD fully enrolled, and I believe it's like over 1,200 patients, which is a very large group in US and ex-US. And so it's going to be very interesting to see how these approaches might really modify the way we take care of our patients, because for some of those patients with neovascular AMD, the burden of injections is just so tremendous. It's interesting as we have these new surgical approaches. There's so much we learn, and we learn from each other, and we learn from our patients. You have a clinical trial, hopefully we see positive results, but then who is the right patient? And that's a discussion that I'm sure we'll be having, in podcasts like this in the future.
Yes, we're going to have a lot of discussions. I think we can do like 12 episodes on gene therapy. So definitely we'll have you back once we have the data from the ABBV-RGX-314 program, because I think it's very exciting. We're one of the top enrolling sites, and we participate in the phase 1, 2, and those patients did great. Okay, so before we close, just anything else in terms of instrumentation, high-speed cutters? I know there's a lot of new technology that you're very excited about.
Yeah, I think if we think about the aura itself, if you think back when we trained in fellowship, it doesn't feel that long ago. I mean, I still think of myself as a young retina specialist. It's changing rapidly, especially when you can get into young ophthalmology lounge at Academy. You realize that maybe
Well, I'll call you a young retina specialist, but mid-career. How about
Oh,
that?
thank you. Thank you. I like that. I like that very much. But I was doing cases 23 gauge, right? Everything was 23 gauge, and there was no 3D visualization. That seemed like science fiction. And now I think our cutters were way slower than what the cut rate was, way lower than what we have now. So I think when we think about innovation in surgical visualization in instrumentation, we really want to make sure that it's safe as possible. You know, whether you're trying to maintain the intraocular pressure in the eye throughout the case, whether you're trying to remove vitreous over the mobile retina and you want to prevent any risk of any iatrogenic damage. If you're trying to, do these complex surgeries and you're trying to incorporate your intraoperative imaging, I think there's just so much that we are learning. And so you want safety, you want ability to make complex maneuvers simpler, and also you want efficiency. And I think that's what we're looking at as we have these newer systems, as we have cutters that are faster, potentially have different instruments so we can go even smaller in terms of our gauge. And as we have these new machines that allow us to control the pressure in the eye more consistently throughout all the steps of the procedure. I think it's very exciting, and also, viewing. And if somebody is really into 3D, you can play with filters and you can really enhance what you're able to see. So I think it's going to be continuously improving, and I think we're going to see this incorporation just like when we started. We were talking how surgery begins in the office. We're going to see incorporation of some of the data that we have from the office then into the OR, so it can guide our decision making as we operate. And I think that integration of the patient experience, if it's a surgical patient, from the clinic to the operating room, and then in operating room knowing what's the best way to manage a complex pathology so you have the best anatomic and functional outcomes. I think it's how we're going to continue to improve the practice of retina.
No, that's a very good summary of the surgical innovation. So you are young because you did not do much 20 gauge surgery. I trained in 20 gauge surgery, and 23 was just coming out, and we had machines with like 700 cut rate, and the bottle will go up and down. So those were the days. So you are still young, I would say. So okay, great discussion. Really enjoyed it. Now let's come back to you. You've been in practice for 12 years, you said. So what is your career achievement that you're very proud of? Now, of course, you have a long career ahead of you, but tell us. I know you teach a lot of fellows and residents, and you publish a lot. You're doing some amazing work with GLP-1s that I've been watching so carefully in diabetic retinopathy. So you have contributed so much. But what do you think that you're very proud of in terms of your achievement?
Well, I've been extremely lucky to be surrounded by fantastic people who are way smarter than I am. And, if I think of what I'm proud of, the moment that comes to mind is something very unique. So, if I may, it's a quick story, but I was traveling, and I was in doing an international meeting. The whole thing where you do like 50 talks and it's with translation in another language, right? And you're trying to understand what actually, especially on a panel, they translate. So they make a joke and you like laugh 30 seconds later. It was a great meeting, but it was an international meeting. I was away from my family. And at some point I thought, why am I doing this? It's I'm flying in, doing the meeting, flying out, as we all have done. And somebody must have heard my thoughts, because as I was coming off the stage, a woman came up to me and she said, I am a resident and I am so inspired by what I just saw. I didn't think I could do retina, and seeing you talk about, whatever I was talking about, she's like, it just made me feel that I could pursue this career. And it was so heartwarming and so kind of her to say this, right? And I think a lot of times we have impact that we have no idea about. It's that domino effect. And as we mentioned earlier, retina is small and big at the same time. And I was just so touched by her comment. And I think, I hope that, I could have helped people along the way without even realizing that. And I think knowing that is extremely rewarding to me.
No, that's a wonderful, wonderful story, right? You're making a global impact by your presence, even though you're sacrificing a lot on your personal life, but on a day-to-day basis, you're making impact by training, right? Residents and fellows from around the world that go and make an impact in their region. So I think in your position, I think you're doing an amazing, let me retake that. I think in your position, you're doing an amazing job, influencing the next generation of retina specialists. So, no, that's a really good story. And then you have another 40 years of career ahead of you, but how do you want to be remembered? It's a question I ask everybody, young or old, for my faculty. So tell me something that you want to be remembered for.
That's a tricky one. It's hopefully I haven't done yet what I'm going to be remembered for.
Well, I think you have. I think you're going to be remembered for being nice and collaborative and innovative and a great speaker. Every time I sit in the audience when you're speaking, I always am like, wow, that was a great talk. So I've been to many talks, as you know. We were in so many sessions together at Retina for years and others. So I think I want to remember you as just a friendly, smart, innovative person who's a great speaker. But tell me what you're thinking.
I think you're ready to write my obituary.
Oh, no. That's not
this is, I think I feel that we're so lucky to do what we do, right? And sometimes days are long, sometimes things are hard. We have patients who have complex pathologies, we have successes, and sometimes we all have failures, right? I hope that I can inspire people because I think, honestly, I just feel extremely privileged to do what we do. It's definitely an honor, and I was lucky to discover ophthalmology, discover retina, and I hope I get a chance potentially to inspire somebody else. But thank you for all your kind words.
No, you're doing great. So thank you so much for being here, Aleksandra. It was a pleasure to have you and learn from you. And I also want to thank the audience for listening in. Thank you very much again.
Thank you. It's been my pleasure.
To earn CME credit, visit medittalks.com, search Retina Radar, or click the link in the notes to complete the activity and post-test. Have a question for our experts? Send it to us at cme@vindicocme.com, and it may be featured in a future episode. Stay tuned for future episodes in the Retina Radar series to keep up with the latest insights and expert discussions.